Paediatric Haematologist based here at Manchester Children's, and I am the HCC lead in the Northwest for sickle cell disease. So the learning objectives for today are to go over the differential diagnosis for a child presenting with chest pain and possible chest syndrome, to go through how we actually make the formal diagnosis of chest syndrome, what are the relevant investigations and the initial management, and very importantly also what we consider for the primary prevention of chest syndrome, and also what we're going to do to try and prevent future episode once an initial episode has occurred. The focus of my talk is going to be paediatric. I am just covering a few little adult bits as well because it's, I think, quite useful just for comparison's sake. So the British Society of Haematology definition of acute chest syndrome is an acute illness characterized by fever and or respiratory symptoms accompanied by new pulmonary infiltrate on chest x-ray. It's interesting to note, actually, the American classification is pulmonary infiltrate involving at least one full lobe of a chest, but the UK just moves to sort of a pulmonary infiltrate. And then it should also be noted that severe hypoxia is a useful predictor of severity and outcome, and is one of probably of the classical markers when we lead to suspicion of chest syndrome. It is one of the most dangerous complications of sickle cell disease and results in the cause of death ultimately of about 25% of adults with sickle cell disease. Due to better recognition and management, the actual mortality of individual episodes has dropped to about 2% in children and 9% in adults, but it still remains sort of as one of the top leading causes of death. And very importantly, in a patient who has had an episode, approximately 50% of these will go on and have a second episode, usually over the next 5 years. And in children, the most common age probably of the first episode is probably between 2 and 4 years of age, so relatively young. The pathophysiology of acute chest syndrome, I'm not sure if you can see my pointer here, but if you think of the child or adult coming in with the painful crisis initially, within sort of the bones, we're getting sort of the occlusion there, and you can often get these little fat emboli or secretory phospholipids coming out, which can then actually go into the lungs, causing infarction. And then coupled with chest infection that's probably also occurring, and also hyperventilation that may be occurring either due to pain in the or alternatively due to the analgesia that's taking place. We then sort of get in sort of hypoxia, which then is incorporating further sickling, and we get sort of this very vicious cycle developing. And the management of the chest syndrome is very much just trying to break that vicious cycle, but it also just helps to emphasize the point that actually many patients, in fact, most episodes of acute chest syndrome will not present with acute chest syndrome, but they'll present with acute pain, very often sort of in the upper abdomen or the ribs or the back, but also sometimes in the long bone. And it's the result of that sort of severe pain and the embolism that's coming from the bones that's the trigger. And again, a lot of the work is trying to prevent the development of chest syndrome from that initial severe painful crisis. So as we said, acute chest syndrome most common between 2 and 5 years of age, and most commonly will present following the development of severe pain, although it can be present on admission. The classical respiratory features are that hypoxia, and the severity and level of the hypoxia is correlated with the overall severity and mortality of the chest syndrome. And we've talked about how the hyperventilation caused by pain or caused by the analgesia will be part of this, and the fat embolism that's coming from the bones. Patients who have an underlying hypoxia are also more likely to develop chest syndrome. So in our paediatric population, that may be patients with asthma. In both children and adults, we see patients with obstructive sleep apnea. And it's one of the reasons why we often undertake an adenotonsillectomy in our sickle patients who have a history of snoring or impaired sleep studies. In adults, the patients who are smokers, which also may incorporate our adolescents, patients who are on long-term opiates, in particular patients who have avascular necrosis and have a chronic pain syndrome. And then other sort of risk areas are during surgery or pregnancy. And then, although we often think of a high hemoglobin as being relatively protective, some patients with sickle cell disease may be running a higher hemoglobin, sort of over the 100 mark, and those patients actually paradoxically may be at higher risk of these chest syndromes. Again, there's often a mistaken thought that most of these are due to infection. In fact, in 2/3 of the case, we will not actually isolate any infection. When we do, the most common ones that have been described are the chlamydia pneumoniae, mycoplasma, and then the viruses RSV, influenza. And we also saw quite a few chest syndromes, especially in the adult population during the COVID epidemic. And our antibiotic choice of sort of the ceftriaxone and also clarithromycin is aimed to really try and target all of these. So what investigations should we be doing? The simple investigations on the blood count will typically show a drop in the hemoglobin, usually of approximately 1 gram per deciliter from the patient's baseline, signifying the hemolysis that's going on. There will usually also be a drop in platelets, has this platelet activation and platelet clumping that may also be going on inside the lungs. The CRP is typically elevated, showing the inflammatory process. And of course, on the blood gas, it's important to demonstrate sort of the hypoxia. And then critically, go on to do a chest X-ray, which in children will typically show the upper and middle lobe involvement. In adults, it's more likely to be in the lower lobes or actually sort of in multiple lobes. But again, it's important to note that during the first 24 to 48 hours, chest X-ray changes may actually not be apparent and may only evolve actually later. May be present on the CT initially, but the actual chest X-ray changes can just take a while to develop. So a normal chest X-ray in a patient with significant hypoxia and other features does not categorically exclude acute chest syndrome. Here's just a sort of slide demonstrating what's going on, which is taken from chest publication here, detailed below. So up at the top here on my left, we have the CT scan of an adult patient who presented with acute chest syndrome, showing sort of the multi-lobe involvement there. From a different patient, here is sort of a post-mortem specimen of the lungs, which is showing in here sort of what essentially is sort of bone marrow appearance within sort of one of the small pulmonary artery, just demonstrating that sort of thrombosis process that's going on and obstructing the blood flow into the alveoli. And if you do sort of sputum induction, you will often demonstrate sort of these lipid inclusions, which are demonstrated here in red on sort of staining, which can come from the patients, which again, just reinforcing that pathophysiology we discussed earlier. The initial management of a patient with chest crisis is first off really good supportive care, trying to get on top of the pain to try and allow better ventilation of the lungs. Careful fluid management and monitoring input and output. We want to avoid fluid overload, so the old tradition of 120% maintenance may actually be associated with a worse outcome. So we want to sort of only go for 100% maintenance maximally. and that can be as a combination of oral and IV, although most patients in this amount of pain will usually not be managing oral. Stating the obvious, we need sort of to ensure that we've got good oxygen and respiratory support, and we'll be looking at maintaining the oxygen saturations of at least sort of 96%. And even if there isn't hypoxia, would usually be given a supplemental oxygen to try and support the pain. Antibiotics, although many may not actually have an infection, given the fact that a third will, it's important to cover sort of the bugs previously described. And as I said, our choice of antibiotics is with ceftriaxone and clindamycin. Blood transfusion I'll talk more about in one of the upcoming slides, but blood transfusion is the life-saving intervention that's going to actually break that vicious cycle and switch off more sickling and allow eventual hopeful recovery. BTE prophylaxis. So certainly for any of our sort of adolescent patients and adult patients, we know that there may be a degree of embolization, which can be sort of both sort of DVT related and sort of PE related on top of the fat embolization there. And certainly these patients with the severe pain are going to be bedbound, and sickle is a very pro-inflammatory process that carries a high rate of thrombosis. And then both incentive spirometry and physiotherapy, although the main role of incentive spirometry is in prevention of this in the first place, incentive spirometry in the milder cases can actually help oxygenate the alveoli and open up the lungs a little bit better, and coupled with good physiotherapy can definitely have a role in the management of the acute episode. As we said, transfusion is the most vital intervention, which is going to actually be the ultimate life-saving event. And it's often a debate whether we should be providing a simple top-up transfusion or a red cell exchange. A simple transfusion will provide obviously dilution of the sickling and usually drops off the sickle percentage to around sort of the 40 to 50% mark, whereas the red cell exchange will provide a much more significant drop in the S level, often to around 15-20%. And the red cell exchange will also ensure that we're not pushing up the hemoglobin too high that can actually cause more hyperviscosity. In general, simple transfusion is more suitable for our paediatric population, especially when putting in a sort of femoral line to enable the red cell exchange might involve a general anaesthetic in a patient who's already struggling. But yeah, simple transfusion better suited for children, a more stable patient, those typically with single lobes and mild hypoxia corrected with low flow oxygen. And because of the time that it can often take to get a red cell exchange sorted out, I think in most circumstances we would always be going for top up first. And many of the sort of local hospitals who are phoning in for support of a patient who might be evolving into a chest crisis, we would usually ensure the simple transfusion is done before transfer down here. Red cell exchange, most of our adult patients, due to that much higher mortality and multilobular involvement, are going to require a red cell exchange. Usually it's more easy to obtain access to provide sort of the red cell exchange in our adult patients. And just a little plug for the adult service, we have both in the children and in the adults, we've got an amazing red cell exchange service that's provided by NHSBT that can go out to all of the hospitals in the Northwest. Although obviously emphasising in the paediatric population, we would usually be bringing them here and exchanging, but we can, if needed, undertake the exchange locally. And then because of risk of alloimmunization in patients with sickle cell disease following an unselected less ideally matched transfusion. It's important to try and ensure that all of our patients with sickle cell disease at their routine clinic appointments have full phenotyping done. And in the emergency situation, we're trying to provide still fully phenotyped blood. However, if phenotyping hasn't been undertaken before or phenotyped blood is not available quickly enough, we would recommend going for at least ABO rhesus and KEL matched blood. But thankfully, certainly here in Northwest, most of our patients have undertaken full phenotyping, and I've usually not come across a problem getting fully phenotyped blood. Moving on to sort of the primary prevention of episodes, then the main focus in our clinics has been sort of hydroxyurea. So out of our sort of 450 patients with sickle in the Northwest under the Children's Service, about 350 of those are on hydroxyurea. It reduces the instance of chest crisis by about 50%. And for those who still develop a chest crisis, has been shown to reduce the mortality by about 40%. Again, we recommend that all of our patients with sickle cell disease are on penicillin V prophylaxis and have a full vaccination program, which should include influenza and also all of the relevant COVID boosters. And then for those patients who are in with a painful crisis, we recommend sort of the incentive spirometry during all admissions. And in randomized study, incentive spirometry has been shown to sort of reduce the rate of chest crisis from sort of 8 out of 19 patients to about 1 out of 18. So I'm just getting quite an echo. I think, Marshall Scott, I'm just putting you on mute because it's coming back from mute. Thank you. I think that's better now. And then just moving on to secondary prevention, obviously, as we've stated, patients who have had one episode have about a 50% chance of having a second episode. And patients are also at an increased risk of having a stroke in the future if they've had an identified acute chest syndrome. Clearly, any patient who's had a chest crisis like this, if they're not already on hydroxyurea, should be, and we would usually move them onto a maximum tolerated dose regimen to try and really get in good protection. In patients who have had chest crisis despite being on a good dose of hydroxyurea, or patients who are absolutely adamant they won't go on to hydroxyurea, it is also a recognised indication for putting patients onto a regular transfusion programme, and it is also a recognised indication for stem cell transplant from a sibling donor or well-matched unrelated donor. And whilst we're waiting on sort of the gene therapy licensing to come through in the clinical trials, it has been an indication for gene therapy in those families who don't have a suitable matched donor. So it's a really key event that should initiate very good discussion about future management. I've just got sort of one short case, which again just highlights some of these sort of other sort of learning points. So our first case was a 7-year-old boy with known SS phenotype of sickle cell disease, had a background history of mild asthma that you will recall was also a risk factor, generally ran the hemoglobin in the 70s, and for various reasons, the family had declined being on hydroxyurea. Patient underwent an adenotonsillectomy at one of the local hospitals, and following on from the adenotonsillectomy, they required oxygen that evening, but were then discharged the following morning when there wasn't an oxygen requirement. However, later that day, the patient presented to their local hospital with good going fever and abdominal pain. Let me just see if I can bring across his other images. Okay, so apologies, my technology is failing to bring across his chest X-ray changes, but on his chest X-ray, he basically had a sort of whiteout on his bottom of his left lung, consistent with chest syndrome. Following sort of discussion, he had a Newt's transfer across to us and was initially started on Optiflow and a morphine infusion to control the pain because he was in significant pain. He was given a top-up transfusion locally just prior to the transfer, and following the initiation of the morphine infusion, he managed to ventilate a little bit better, and we saw his pain come down and his oxygen saturations markedly improve. However, then during the night, he developed further oxygen requirement and pain, and we took the decision to undertake an emergency red cell exchange that was undertaken on our ICU following a femoral vas cath that was actually put in just under local anaesthetic very, very successfully. And he was a really brave lad for going through that. And again, he made a great recovery, and probably about 3 days after the red cell exchange, he was out of oxygen and sort of back home. Despite all this, the family is still refusing hydroxyurea, and we're still in discussions about how to still try and better manage and protect him long term. But again, this case just highlights certain high-risk situations such as surgery. The risk of acute chest syndrome following sort of surgery is of the order of about 40% in patients who don't undergo sort of transfusion beforehand. And even with preemptive transfusion or red cell exchange, the risk of chest crisis is not completely eliminated and still remains of the order of about 10%. So just remember, even if we put that in place, it doesn't mean that we can be absolutely sure that the patient won't undergo complications of the sickling. And we generally recommend sort of transfusional red cell exchange for sort of moderate or high risk surgeries. So those are generally sort of surgeries involving the airway, involving the gut, or those where there'll be a prolonged anaesthetic time. And really, only the patients who we would recommend a non-transfusion approach really are sort of our hemoglobin SC, our S beta plus sicklers who have a milder clinical phenotype, or our patients with SS who are on hydroxyurea and are demonstrating a good hemoglobin F level, which provides protection, and whom haven't had sort of recent crisis. In those patients who are running sort of we would expect to be running a good hemoglobin, and those who are undertaking low risk surgery can be managed with no transfusion. But essentially everybody else is going to need either a simple top-up or a red cell exchange. For the patients who have a lower hemoglobin, sort of below sort of the 85 mark, we can usually manage them with a top-up and we'll be able to dilute the S level sufficiently. However, those with a higher hemoglobin, which infuriatingly may be those who are on hydroxyurea but haven't quite gained the full protection of it, will need a red cell exchange. And again, that takes quite a bit of planning around the surgery. Okay, so that really sort of concludes the main part of my presentation. So just going over again, what I try to ensure is we understand sort of the differential diagnosis, i.e. infection, and just simple sort of pain. When we would diagnose a chest syndrome, what the investigations would be, the initial management. And then we've also talked a bit about primary prevention, in particular about the important role of intensive spirometry, and the secondary prevention, i.e. ensuring patients are on a good dose of hydroxyurea, but also flagging that chest syndrome is a clear indication for either regular transfusion program, transplant, or gene therapy. I have circulated these slides to Zishan for onward circulation, and this is similarly being recorded and will be going up on the HCC website under our sort of learning section. But there's a few other areas where the full guidelines can be accessed, which are all sort of freely available on the links here. And if anybody is interested, please go on to that. Otherwise, I will stop screen sharing and open.